Hi, my name is Jennifer Kai, and I'm a gastroenterologist at Brigham and Women's Hospital. I want to thank IFFGD and the organizers for this invitation to speak. And today I will be presenting on the topic of belching. So let's jump right in. What exactly is belching? It's commonly known as a burp. And this occurs when gas suddenly escapes from the esophagus or the stomach to the top of the throat, causing an audible sound. And it can be normal to belch. But when does it cross the line to become excessive belching? As I mentioned, belching can occur in healthy individuals, but it becomes a disorder when it's bothersome enough to impact usual activities for greater than 3 days per week in the preceding 3 months and with the onset of symptoms at least 6 months before the diagnosis. Belching can also occur with many other conditions, including reflux or heartburn, in which case it can occur in up to 50% of cases. Gastroparesis, which is delayed emptying of the stomach, pregnancy, psychological disorders, as well as in patients with hernias or a history of a stomach wrap surgery. Worldwide prevalence of belching is about 1%. Now, there are several types of belching. The first type is called gastric belching. This is the most common form. We swallow a tiny bit of air each time we eat or drink something, and belching allows all of this accumulated air to be released from the stomach. As we see on the diagram, air moves from the stomach through the esophagus, which is our food pipe, and out the mouth. This process can normally occur up to 30 times a day. Often when we talk about belching, the term air swallowing also comes up. So what is air swallowing, and how does this relate to belching? Excessive air swallowing is also known as aerophagia, and this is the process where air enters the esophagus by contraction of those esophageal muscles called peristalsis. Then the lower esophageal sphincter, which is the muscle that connects the esophagus and the stomach, will relax, and air will flow into the stomach. You see here that the directionality of the arrow is the exact opposite of what happens in gastric belching. So it's no surprise that air swallowing can actually worsen gastric belching. Air swallowing is also associated with bloating and distension as air travels further down to the intestines. This is a common condition and can be present in up to 30% of patients. Now, there are certain dietary habits that can make air swallowing and belching worse. These include drinking carbonated beverages, eating hard candies, chewing gum, and for those who are lactose intolerant, ingesting dairy. And finally, certain carbohydrates, such as broccoli or cauliflower, can also increase gas production, leading to belching. Now, let's move on to a real-life patient case that offers a practical example of disordered belching. In this case, a 25-year-old woman who has a history of reflux and anxiety has been suffering from frequent belching that can occur up to 70 to 80 times a day. This has impacted her ability to finish a meal, participate in events, and even work. Her belching has worsened over the past 8 months after an infection that caused several days of nausea, vomiting, and abdominal pain. This is an example of the second type of belching, known as supragastric belching. This can occur in 3.4% of patients with upper GI symptoms. In this case, air is suctioned into the esophagus due to either the diaphragm, one of our breathing muscles, or by an increase in throat pressure. As that suctioned air goes into the esophagus, it is then immediately expelled without ever reaching the stomach. So, unlike gastric belching, this excessive air swallowing is not thought to be related to supragastric belching. Supragastric belching is also initially thought to develop as a voluntary response to abdominal or chest discomfort, or in some cases, increased stress. As the belching continues, it can then become an automatic response where the patient has no control over when it occurs. Supragastric belching can be associated with psychological factors such as anxiety or depression. And interestingly, the absence of belching is noted during sleep, when speaking or when patients are distracted, and also can be worse after and during stressful events. So, how do we differentiate between these two types of belches? Your doctor may recommend two different tests which use catheters or thin, flexible tubes inserted into the nose to measure pressure and acid levels in the esophagus. These tests are called esophageal manometry, the figures in blue and green, and a pH study, the figures in pink. These tests can show whether the air actually reaches the stomach or stays in the esophagus. You may also ask, why is it important to differentiate which type of belching you have? Because this treatment strategy will often depend on that. If you have supragastric belching, behavioral treatment is a mainstay, and they may include diaphragmatic breathing, which uses your diaphragm muscle instead of your chest muscles to breathe. Practically, you will see your belly push out when you inhale and fall back in when you exhale. Cognitive behavioral therapy is a type of psychological treatment that helps you notice and change unhelpful thoughts and behaviors. Relaxation training, gut-directed hypnosis, and speech therapy can also be effective tools. If your belching is thought to be primarily related to reflux, then an acid-blocking medicine such as a proton pump inhibitor may be helpful. And then finally, neuromodulator medications such as baclofen may help the lower esophageal sphincter not open and close as frequently to prevent belching. Importantly, there are also dietary and lifestyle changes that can be made to help belching, including avoiding those foods and drinks that can cause gas, trying to eat more slowly and chew food thoroughly. For those of you who have dentures, ensuring that there's a proper fit, and also smoking cessation, all of which can increase the rate of air swallowing and belching. And finally, taking a short walk after eating may also help with digestion. I also want to briefly mention a disorder that is related to belching called abelchia. Abelchia actually means the inability to belch. So this is a related but opposite problem where the muscle that connects the throat and the esophagus doesn't relax properly to allow gas to escape. Symptoms may include chest pain, gurgling, bloating, and distension. If you have abelchia, you can ask your gastroenterologist or your ear, nose, and throat doctor about whether a Botox injection to that muscle, noted by the arrow there, can be helpful. Finally, I'd like to end with a few words about how to discuss belching with your gastroenterologist. Belching can sometimes be an uncomfortable and perhaps even embarrassing symptom to discuss, but being open in describing your symptoms can help your doctor figure out what's really happening. You might consider starting a 2-week diary to track your symptoms as well as your eating habits. Some things to potentially include in that diary include frequency. How often are the belches? Do they come and go, or are they constant? Timing. Does it occur after eating or drinking certain foods, or when you're feeling anxious? And then, are there associated symptoms? Any heartburn or regurgitation, difficulty swallowing or abdominal pain, nausea or vomiting, bloating or weight loss? Some of these symptoms may be alarm symptoms, and you should tell your doctor. And then finally, let your doctor know if you have any other GI conditions or disorders, as this may impact their assessment and treatment of your belching. Thank you so much for listening.